Hello, friends, and welcome to episode 1266 of the Juicebox Podcast. Hey, Dr. Blevins is back today to speak about Afrezza, the inhaled insulin. You know, I love Dr. Blevins on the GLP episode, so I thought, I wonder what else this guy knows about. Today, we're going to find out. He actually runs a lot of studies out of his Austin practice, so if you're interested in some type 1 studies, you should reach out to him. He tells you how towards the end. Please don't forget that nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan or becoming bold with insulin. Don't forget, if you use my link, drinkag1.com/juicebox, you'll get a free year supply of vitamin D and 5 free travel packs with your first order. And if you go to CozyEarth.com and use the offer code JUICEBOX at checkout, you're going to save 30% off of your entire order. Kids, don't forget t1dexchange.org/juicebox. If you're a type 1 or the caregiver of a type 1 and a U.S. resident, I need one and would love if you would go over there, join the registry, complete the survey. It takes about 10 minutes. You're going to be helping type 1 diabetes research while you're supporting yourself and me. This episode of the Juicebox Podcast is sponsored by the only implantable sensor rated for long-term wear, up to 6 months, the Eversense CGM. EversenseCGM.com/juicebox. This episode of the Juicebox Podcast is sponsored by US Med. USmed.com/juicebox or call 888-721-1514. Get your supplies the same way we do from US Med. This show is sponsored today by the glucagon that my daughter carries, Gvoke HypoPen. Find out more at gvokeglucagon.com/juicebox. Everyone, Dr. Blevins is back. You might know him from some of the GLP conversations we've had recently, but today he's here to talk about Afrezza, which is, of course, the inhaled insulin. Dr. Blevins, welcome back.
Scott, good to be here. I do want to point out to the audience that I participated in one of the studies with Afrezza, or actually a couple of studies, and I'm actually one of their advisors. So keep that in mind. And it's great to be here. I think this is a type of insulin that everyone needs to know about.
Why do you think?
Well, I think it's because number one, it is unique, and it's quite unique, and it's kind of less known about, and people need to know about it as an option. Mm-hmm. And it's unique in that it gets in so quickly. First of all, it's inhaled. That's unique, and it gets in very quickly and out very quickly. And I'm going to talk more about that.
Right. So how long has Afrezza been in the marketplace?
You know, I think if you ask people how long, they would say, oh, it's brand new. And the answer is it's not at all. It was approved by the FDA in 2014. And it started off being licensed to Sanofi. And then it returned to the company called Mankind, which is where it exists right now, the company Mankind, in 2016. Some people may remember that in the past, a very, very impressive person named Al Mann actually developed the insulin. He saw this potential of a dry powder, and he knew that if it was inhaled, it would get into the blood very quickly. And he put a lot of his own money into it. And you might also remember that he was the guy that helped develop the MiniMed Medtronic insulin pump.
No kidding.
Yeah.
How about that? Listen, when people are passionate about things, that's how you get different and change, you know, because it's easy to get behind a thing that exists. But if you have this kind of, because it's not so much, well, not that it's not difficult to make something work, but once you make it work, it's the selling it part. And I don't mean the financial part. I mean the explaining it to people and letting them know what it is and getting them to try. Like that's where a lot of the really difficult work is. Because, you know, and so that's what I don't want. Like, I don't want to be a barrier for people listening, because I was presented with the idea of letting Arden use inhaled insulin, forever ago. And I said, I don't know enough about it. And, you know, just hearing what I'm hearing, I'm like, I don't know how thrilled I am about my daughter just inhaling something. And she was young, so we didn't really look back at it again. Yeah. So I'm interested to hear what you think of it and what this study showed.
Yeah. Well, many people remember the first inhaled insulin came in a bong, really literally what we would call a bong. I'm looking at one across my room. I kept it up in my history of diabetes shelf there. And it was a big mess. You had to put the little medicine in a little sort of a bong, and it humidified it a little bit, it aerated it a little bit, and then you took the big bong up to your mouth. And this now the Afrezza comes in a very little, small inhaler, very simple and very portable and very discreet. And I think that's one of its advantages.
And so I've had it described to me before, but what's the process of inhaling it? And it's a powder, is that right?
Here's what happens. It comes in 3 doses, which we'll talk about more in a minute, and a small amount of powder if you look at the cartridge. And the cartridge is then just inserted into a simple little inhaler that measures about, I wish you could see it, but it's about 2.5 inches or something like that in length. And it's about maybe 1/2 to 3/4 in width and depth. And just clip it in, put the inhaler up to the mouth and aim so it goes into the airway and not in palate or the tongue, and then take an inhalation, and then that's it, and take a deep inhalation, and that is the dose.
Okay.
So I was going to mention this later too, but it's very discreet. A person could be in a restaurant, just reach in, put the cartridge in, flip it in, no injection, no pin needles, no pins, that kind of thing, and those are pretty discreet too, I think. But don't get me wrong, but many people run into the restroom to give their insulin injections in a restaurant or when they're out in public, and they don't have to. But the inhalation is very, very straightforward. And I've had quite a few patients who sit in a board meeting and they're taking their medicine and it doesn't interrupt them or anything else.
No one knows. It reminds me of a whistle when I look at it. Like that kind of size, you know what I mean? Not large. Yeah. And then that's disposable when you're done, right?
Well, the inhaler lasts for about 2 weeks at a time. The little cartridges measure maybe 3/4 by 1/2 an inch or something, and they are disposable. They can be carried in the person's pocket. They can be carried in a purse or that, and they're very portable, and they are disposable after they're used.
Okay. So inhaler that a cartridge goes into, I inhale that. The cartridge is disposable, but I can use the inhaler for a bit.
That is exactly right.
Got it.
Usually 2 weeks at a time is what's recommended. And I'll tell you something too, Scott. When people inhale, I've seen kind of models. There's a kind of a mock-up over at the Mankind manufacturing facility and the Afrezza manufacturing facility. And when people inhale, this powder gets into the lung very quickly. And the advantage here is that it gets across the alveoli very quickly. And some people ask, well, what is the surface area for absorption of the lung? It's about the size of a tennis court. I mean, those lungs they're absorptive machines. So getting something across that rapidly is very doable. You put it on a carrier. There's something called a technosphere microparticle that the insulin is attached to, adsorbed to, and then once the inhalation occurs, that gets out to the alveoli. It gets across into the circulation immediately. Mm-hmm. And I can say something about the rate of absorption and compare it to other insulins too.
So people don't get confused. I think I understand, but your lungs are just a great pathway to get the insulin to your bloodstream. If you take insulin or sulfonylureas, you are at risk for your blood sugar going too low. You need a safety net when it matters most. Be ready with Gvoke HypoPen. My daughter carries Gvoke HypoPen everywhere she goes, because it's a ready-to-use rescue pen for treating very low blood sugar in people with diabetes ages 2 and above that I trust. Low blood sugar emergencies can happen unexpectedly, and they demand quick action. Luckily, Gvoke HypoPen can be administered in 2 simple steps, even by yourself in certain situations. Show those around you where you store Gvoke HypoPen and how to use it. They need to know how to use Gvoke HypoPen before an emergency situation happens. Learn more about why Gvoke HypoPen is in Arden's Diabetes Toolkit at gvokeglucagon.com/juicebox. Gvoke shouldn't be used if you have a tumor in the gland on the top of your kidneys called a pheochromocytoma, or if you have a tumor in your pancreas called an insulinoma. Visit gvokeglucagon.com/risk for safety information. I used to hate ordering my daughter's diabetes supplies. I never had a good experience, and it was frustrating. But it hasn't been that way for a while, actually for about 3 years now, because that's how long we've been using US Med. usmed.com/juicebox or call 888-721-1514. US Med is the #1 distributor for Freestyle Libre systems nationwide. They are the #1 specialty distributor for Omnipod DASH, the #1 fastest growing tandem distributor nationwide, the #1 rated distributor in Dexcom customer satisfaction surveys. They have served over 1 million people with diabetes since 1996, and they always provide 90 days worth of supplies and fast and free shipping. US Med carries everything from insulin pumps and diabetes testing supplies to the latest CGMs like the Libre 3 and Dexcom G7. They accept Medicare nationwide and over 800 private insurers. Find out why US Med has an A+ rating with the Better Business Bureau at usmed.com/juicebox, or just call them at 888-721-1514. Get started right now, and you'll be getting your supplies the same way we do.
It is.
Okay.
They are, as it turns out. Of course, your lungs get oxygen across immediately, quickly, and they also deliver carbon dioxide back out.
Mm-hmm.
So the lungs are sitting there, they're delivering oxygen, removing toxins, you might say, or metabolic products in a way. And also people take like inhalers for their lungs to dilate the lungs. If they have asthma, they take inhalers for all kinds of things.
Right.
But also it's a great absorption organ, and things can get across into the circulation very, very promptly if they're delivered properly. And inhaled insulin gets that insulin out there to the alveoli to be absorbed.
Why don't we see more medications delivered this way?
You know, I think there's been a big focus on medicines that treat like asthma and emphysema, things that are aimed at the lung itself. Yeah. And a few medicines can go across the lungs. Not every medicine. You have to have a small, relatively small particle that gets across the alveoli. So I think you'll see more meds that are delivered that way. And certainly inhaled insulin is here and now. And, you know, it's been out since 2014. And we look at it as something new because many times it hasn't been talked about, really hasn't been used as much as it should be. And I think part of that was the initial, I mentioned a while ago, the thing about the bong. The bong was a real inhibitor to use. And then along came pens that made giving rapid insulin more feasible and more doable. So the excitement about inhaled insulin sort of faded. And now many times practitioners and people with diabetes just don't think about it. I mean, I have people, unfortunately, I'm a culprit too when it comes to not talking to people necessarily about every single option. I make myself do it as much as I can. And now I talk to people about inhaled all the time because it works so well. And we have now very good data that shows that inhaled insulin can be very effective.
Versus injectable?
Yeah, versus injectable. And I can say a few words about injectable. Of course, I mentioned earlier, we did a study with Afrezza here at my clinic here in Austin, Texas Diabetes and Endocrinology. We do quite a bit of phase 2 and phase 3 clinical research. And so we did a study. We've done studies with other insulins too. And with the newer, more rapid acting injected insulins like, and I'll say the name brand because people understand them when you talk about name brand, Fiasp, which is fast-acting Aspart, which is a fast-acting Novolog. We did studies here with Lyumjev, which is fast-acting Lispro. They're called fast-acting, they're called ultra-rapid, but they really don't come close to the rapidity of absorption of the Afrezza. And let me go through, if it's okay, let me just give you a few numbers.
Yeah, please.
Okay, so there are 3 measures that are kind of interesting to look at when it comes to absorption of rapid-acting insulin. One is time to first measurable effect. The other is, so the first effect it has at lowering the sugar. Mm-hmm. You know, once you give a dose, it takes some time for it to have an effect. And when it comes to injected insulin, what delays the effect is the fact that it's given in the subcutaneous space, and it has to break down into a single molecule of insulin before it can get absorbed. It's given typically in a cluster of 6, like it's called hexamer. So when you give insulin, typical insulin sub-Q, the rate of absorption has everything to do with how rapid it becomes a single molecule. That single molecule can be absorbed. A single molecule is called a monomer. So, you want to go monomeric as quickly as you can if you give sub-Q, because that's what allows it to get absorbed. That takes some time. Even the most rapid sub-Q insulins take time to get absorbed, longer than Afrezza. Afrezza, inhaled, it's into the system right away. It is monomeric to begin with, by the way. It doesn't have to break down. There's no subcutaneous tissue for it to break down into. It gets in right away. Okay. And that leads to another very important characteristic, and that is it also gets out quickly. It doesn't linger, and I'll tell more about that. So time to first effect, time to peak effect, and time for the insulin to return to baseline. Now let me give you some comparisons.
Yeah.
And interrupt me if I'm not clear. And you in the audience, you just make notes in your mind or on paper if you want. And I'm going to go through those measures for Afrezza, Fiasp, and also Lyumjev.
Okay.
And those are the best competitors because those are the most fair competitors. They're the most rapidly absorbed sub-Q insulins. So time to first measurable effect of the middle dose of Afrezza is kind of a middle dose is 12 minutes. So it gets them pretty quick. The first measurable effect. Time to first measurable effect of Fiasp, 17 minutes. So it's not as fast as Afrezza, but it's relatively quick. First measurable. And the same is for Lyumjev, 17 minutes. So that's interesting. Time to peak effect. So once it starts getting in, you want it to get in quickly, right? Most people with diabetes will tell you, I want my sugar to be affected right away. And I have to wait and wait. Well, time to peak effect is about 45 minutes for Afrezza at the middle dose that was studied. So that's about 45 minutes. And you may say, what do you mean 45 minutes? Well, what do you think is going to happen with Fiasp? Time to peak effect is 122 minutes. And Lyumjev is 138. This is right out of the product insert. This is right out of what is published for people to see. So that's the peak effect is much faster with the Afrezza. So if you take it, you're going to get an effect more rapidly, peak effect. What about duration? And let me just say, you may ask, why is duration important? Well, duration is really important because when you dose insulin, you really want it to act quickly. And you don't want it to hang around because you can have hypoglycemia if there's a long tail on the rapid acting insulin. Does that make sense?
Yeah, it also makes sense to me that if I needed to redose again, I'd like to be able to feel relatively comfortable that what I did first is gone. This episode of the Juicebox Podcast is sponsored by the Eversense CGM. EversenseCGM.com/juicebox. The Eversense CGM is the only long-term CGM with 6 months of real-time glucose readings, giving you more convenience, confidence, and flexibility. And you didn't hear me wrong. I didn't say 14 days. I said 6 months. So if you're tired of changing your CGM sensor every week, you're tired of it falling off or the adhesive not lasting as long as it should or the sensor failing before the time is up, if you're tired of all that, you really owe it to yourself to try the Eversense CGM. EversenseCGM.com/juicebox. I'm here to tell you that if the hassle of changing your sensors multiple times a month is just more than you want to deal with, if you're tired of things falling off and not sticking or sticking too much or having to carry around a whole bunch of extra supplies in case something does fall off, then taking a few minutes to check out EversenseCGM.com/juicebox might be the right thing for you. When you use my link, you're supporting the production of the podcast and helping to keep it free and plentiful. EversenseCGM.com/juicebox.
Exactly. Yeah. And that where you're talking about, you don't want to stack because once the sugar goes up and you're disturbed by it, you're tempted to redose it.
Right.
Hit it again. That might bring it down more quickly, but unfortunately, that insulin can hang around, and the tail of the first dose, the tail of the second dose can cause you to become hypoglycemic, and that is stacking. So the duration is a big deal. That leads into what is the time for the effect to return to baseline of Afrezza. It's about anywhere from 90 to 180 minutes. And let's compare that to the other two. Remember, they're the fast ones. The Fiasp time to return is 5 to 6 hours.
Oh, right.
It is.
Yeah.
And the time for Lyumjev, which is it's a fine insulin. We use a lot of it, of course. But the time to return to baseline is 4.6 to 6.2 hours. We're not talking, remember, Afrezza is 90 to 180 minutes. So what you said is exactly right. You want the insulin in, but you want it out. And if you want to redose it, you want to be comfortable that first or the prior dose is not going to be hanging around to cause you to get low later on.
Right. Especially if you underdose a meal, for example, or it's fatty and you don't go after it correctly, and then you do have to hit it harder, but then eventually that logjam inside breaks and the food passes through and it's no longer impacting your blood sugar. All the leftover insulin is just it's a lead weight then.
It is.
I know it's not part of what you want to talk about, but if I asked you to go over like Novolog or Apidra, would they be significantly different than Lyumjev and Fiasp?
Yeah, they're slower in and they're going to be slower out.
Okay. But they don't go over 6 hours still, though, do they?
Oh, they do. They go 6-7 hours duration.
Okay.
Yeah, they do.
Wow.
And they peak later. Most people, if you ask someone who has diabetes or even practitioners to write down the peak time of various of these insulins, they think it peaks sooner. And it doesn't. People with diabetes know. They take a dose and they know it takes a while for it to kick in. And they just are patient and many times very impatient, though, and they like something that acts faster. And the fastest insulin on the planet is Afrezza. It gets in quick. And one of its big advantages is also, and I'll just say it again, that it gets in quick, it gets out quick.
Mm-hmm. Yeah, no, it's a big deal. And let me stop you here for a second to highlight what I think might be some people's concern.
Yes.
What, if anything, about it is dangerous or concerning? It's the idea of inhaling. I'm still listening to you and thinking but inhaling something. And I don't know if that's based in just a nonsensical fear or if that's a real thing I should be worried about.
Well, I mean, there are things that are cautions that people need to know about when they use it inhaled insulin. One is there are side effects potential. Cough can occur in a significant number of people. It tends to get better over time. I tell my patients when I start them on Afrezza, I say, you may cough and you may see some powder come out. It's okay. It doesn't mean anything. Enough has gotten absorbed. I can tell them that's what the studies show clearly. Enough has gotten absorbed if you cough some out. So cough can occur, sometimes sore throat, which tends to be transient. I had one person who developed a very sore throat initially, and we thought we were going to have to stop the medicine. She kept taking it. It went away. Mm-hmm. And so there are certain people also who shouldn't be taking it. And those are people who have some kind of any type of chronic lung disease, like chronic recurrent pulmonary disease. That would be asthma or COPD. We don't prescribe it for Afrezza for people who have those conditions. Right. And there are some people who are hypersensitive to human regular insulin too. Of course, they have trouble with any insulin. And we also know that when people take Afrezza, there is some reduction in a measure of lung volume called FEV1, and it can reduce a small amount, usually about 1%, 30 or 40 cc's of lung volume reduction when on the Afrezza. Now, interestingly, when people go off the Afrezza, it comes right back. So it's not a permanent thing. But let me also put that into context. Well, 40 cc's of reduction. Well, what is the typical male-female lung volume total? That's about anywhere from, males have greater lung volume than female, but it ranges anywhere from 3.5 to 4.5 liters. And I would just say, make it easy, it's 4 liters. And you know that 40 cc's of 4,000 cc's is a tiny amount.
1%.
So that is important to know. People see that the lung FEV1 can reduce, but it's really a tiny amount. what we do, and it's important for everyone to know, we do typically we do a measure of lung function at baseline, or at least when we decide to continue the Afrezza. That's called the FEV1. It's a simple little test we do in the office, and there's a little machine I can hold in my hand that will allow me to get an FEV1. A person breathes into it. So we do it at baseline, after 6 months, and then about once a year. That's the current recommendation. And if there's a decline of over 20%, then we would discontinue the medication. So the safety's good. We know what kind of changes we might see, and we measure for them. Those are the primary sort of concerns. There's people sometimes have, in the past, have said, well, what about lung cancer with inhaled insulin? And let me just make a long story short and say that there were some cases reported. One of them occurred very soon after a person started, so it couldn't be related. And they're just really tiny numbers, and there's no sign or signal here that I can detect.
Yeah, so stuff like this, am I right to say, exists with almost every medication you take? So, I mean, like, there's some people who are just not going to work well for, and some people are going to have an adverse event that you have to discontinue because of. But is it any more or less so than other things? I mean, or I know with injectable insulin, you can't just stop if you have type 1 diabetes, because I've interviewed people who have like significant insulin allergies, and it's very infrequent, thank God, but it's horrifying, and they had to just keep doing it. Actually, those people end around their problem by using Afrezza in some situations. Do you know what I mean? Like, my question is this something that's more concerning than any other general situation I put myself in with the medication?
And Scott, my answer is I think not.
Okay.
I think that there's been a lot of caution, fortunately, as there should be, and careful evaluation of data, as there should be. The route of administration is unique. To me, the greatest side effect or adverse reaction related to insulin is hypoglycemia. If I have an insulin that is associated with less hypoglycemia, then I'm going to be really happy. Mm-hmm. And I will say that not every, but some of the studies with Afrezza have suggested lower risk of hypoglycemia because it doesn't hang around so long. So to me, the greatest risk of insulin is hypoglycemia, be it inhaled or injected. And so finding a quick in, quick out insulin for mealtime, for rapid acting, or for intervening when the glucose is high is an advantage.
I still need a basal insulin if I'm using it, though, correct? So I'm going to inject a basal?
You do.
Okay. And so this is for meals or affecting high blood sugars, or for somebody who's using a pump to bring a high blood sugar down. Are those the use cases that you see?
Yeah, I'm going to say yes to all of those. I will point out that the approval currently is for adults. It's not approved for children yet. There's a big study that's been conducted that is looking at that possibility, and don't have results yet. And I'm optimistic, but I don't know yet. It's approved for adults with type 1 and also type 2. So certainly the adults with type 1 have to have basal. Most of the people with type 2 will have to have basal too, but there's some people with type 2 that might not need it. But you're also exactly right on. This is for mealtime, to get in quickly and cover the meals quickly. You know, when a person doesn't have diabetes, the pancreas doesn't wait. It doesn't peak the insulin at an hour. It peaks it quickly. And this gets about as close to that as possible. So mealtime is number one. Number two, if a person's low 2 hours after a meal because of the short duration, they can redose it. And we had people do that in the study. And people on pumps, if they have a high reading and they want rapid reduction, they could use it too. And I'll point out in a bit that in the study that we conducted, we had people who went off the pump to go on the study, and they went on to a basal plus Afrezza, and many of them afterwards decided that they would want to stay on the injected insulin with the Afrezza. And we had a couple people who were on pumps that decided to use the automated pump as a background, and use Afrezza for the mealtime because of the rapid effect.
Is that a thing that insurance is covering?
Our results when it comes to getting things covered recently has been better and better.
Good.
Yes.
Do you see, it might feel like it's off base for a second, but I've now interviewed 3 people who probably have LADA who started a GLP and now are almost completely off of insulin or completely off of it for the time being, I imagine. But they still see excursions at their meals, and they get some of them are afraid to use insulin at the excursion because, like you said, the insulin lasts so long. Would this be a better fit for that, do you think?
I have to admit I haven't used it in that way, but I will tell you that your thinking is exactly right. Mm-hmm. It's quick in, quick out. And when a person has beta cell failure, near failure, or impending failure, the first thing to go is the postprandial, and the cells just can't keep up with the need. And so, yes, Afrezza would be a reasonable option in that case. So I think you have to. You're doing the right thing, Scott. You're thinking through, and that would be one. Wrap it in, wrap it out. That would be a good potential. If a person has a high sugar at bedtime, Afrezza gets in, gets out, doesn't hang around overnight.
Make you low at 3 a.m.
different times. Yeah.
Everything I think about insulin is about timing and amount, like meeting need with impact. That's just kind of how that's the entirety of the way I think about managing diabetes. Yeah. So it's interesting. Approved for type 1s and type 2s?
Yes.
Okay.
It is.
But adults, what is that, 18 and over? Or what's the cutoff at the moment?
It is adults 18 and over.
All right.
And we're hoping for an approval that goes down to much younger. And it would seem to be a very usable treatment for the pediatric population because it's discreet, it's quick, and you get rapid response to hyperglycemia. And that just really fits the PD population. But a study has to be done, and then approval has to be obtained.
Are there smaller instances of low blood sugars with Afrezza versus injectable?
There have been a number of studies that have looked at that, and I could go through them by name, but one study in adults with type 1 showed that Afrezza as rapid-acting insulin reduced the A1C or maintained it or reduced it just as well as in that study they were using actually insulin aspart, which is Novolog, and also shown also in people with type 2. And there are a couple of the studies have shown a reduction in hypoglycemia as well because of the shorter duration of action.
Okay, what's interesting? Am I missing anything before I ask you to move on to the study?
Well, I can say that there are a couple things. I might talk about the dosing.
Yeah. Oh, please. You know what? Yeah. How did that slip my mind? That is the most confounding part of this. And even when I ask people, listen, I asked the CEO of Mankind. I was like, explain the dosing. And the explanation feels a lot like art and not a lot like science. And I get that insulin is that in general, but I guess in a world where people are used to hearing my insulin to carb ratio is this, my insulin sensitivity is that means if I do this, then this is how much insulin I use. This seems vague, I guess. So how does it fundamentally get used in a real world situation?
Well, let me explain some of the dosing when I go to talk about that study, because I think that study helps define the right way to dose. And that's why.
Okay.
But let me also point out that Afrezza comes in 3 doses. One is called a 4-unit one, and I say is called, and I'll explain that in a minute. One is called a 4-unit, one's called an 8-unit, one's called a 12-unit. The FDA requires Mankind to assign the number to the cartridge relating to the amount of insulin in each cartridge. Okay, that makes sense. But in fact, when you inhale insulin, some of it gets caught in the inhaler a little bit gets caught in the oropharynx, and a little bit gets caught in the upper airways, and it's not going to get absorbed. And so what I tell patients is there are 3 doses, 4, 8, and 12. And you can't imagine how many people tell me, 4 is way too much for me. And I say, well, it turns out that 4 is 2 when it comes to the amount that gets into the absorptive area of the lung. I'm going to also tell you that is an estimation, but it works. 4 is 2, 8 is 4, 12 is 6. Mm-hmm. So if you are on 4 units pre-meal and you're going to change over to Afrezza, do you dose the 4-unit cartridge? And, you might do the carb count. I'm just going to say, if you're on 4 units most time before meal, do you use the 4-unit cartridge? And the answer is you can, but your sugar's not going to do as well because it's really only 2 units. So we tell people to use that conversion. 4 is 2. And by the way, this seems a little confusing, but I've given this conversion to so many people now. And the next visit, you know what they do? They come back and say, remember, 4 is 2, 8 is 4. they understand it very well. And it's very straightforward. 4 is 2, 8 is 4, 12 is 6. And now that may have to be adjusted. That ratio may not be true for everybody, but that works. So you can get people who are very, very sensitive on a 4-unit cartridge, and they're really just getting about 2 units, and that works. Okay. And then people who have to take more than, like, if they need like 8 units, in reality, the 8 units of their usual insulin, then they would have to take a 12, and then they would have to take a 4 to get up to 8, because 12 is 6 and 4 is 2. And they can do that. They can take one inhalation, then go add, cartridge switch really quickly and inhale again. It's very fast. It works.
Do you think, I mean, you've spoken to a number of people, obviously, who use it. So what's the response you get back from people using Afrezza? Do they find it easier? Do they find it more difficult but worthwhile? Like, what's the user experience with outcomes?
Yeah, we learned that in the study. Quite a few people who actually had been on the pump before actually decided they wanted to stay on Afrezza, either with or without the pump, either with the pump or with basal insulin. So some people really, really like it. Not everyone. It's not for everyone. It's an option. And the critical thing here is that we need to be talking to people, we practitioners, other people who have diabetes, need to be talking to people about this. It is an option, and people should be exposed to all of the options available. I know that's one of my jobs in medicine, period, to say, hey, these are the things we can do. And I give people samples, I let them try it. And if they like it, we move on. Lots of people want to get the prescription after they try the sample. I tell them about it. So a lot of people really do want this type of insulin activity. Some of the responses I've gotten have been, I want to continue it. One of the responses I got from a somewhat elderly gentleman, there's no age limit on the upper end. And he told me, which he said, no one told me that an option like this existed. And I felt very badly because I'm his doctor. And that was my thing. He was sort of a little bit indignant. And I realized I'm going to change the subject here. He's doing really well on it. And I've had a few people say, is this insulin new? Because they like it. And why haven't we done this before? Right. And another person just said simply, it's kind of the same thing. Why didn't we start this before? This was a person on the study, not a person I was taking care of, as it turns out, in my own personal practice. But when she volunteered for the study, and she says, wow, this stuff has this effect. Why didn't this get started before? So and some people say, it's not for me. I'm coughing. They have the side effect. It's not for everybody. And some people say, well, I like the way it works, but I really want to get back onto my pump and that too. So we had quite a few people. I could give you some stats on that here in a bit.
Yeah, I imagine that's just going to be the case with everything. But I think to hear that if I begin to take it and I get the cough and I don't like the cough or it doesn't dissipate eventually, stopping puts me right back to where I started again. Is that correct?
That's right.
Yeah.
That's exactly right.
So nobody's going to experience permanent damage as far as the studies have shown, or your experience.
That's exactly what the studies show when it comes to the FEV1, that lung volume thing. Okay. And the cough will go away as soon as a person stops the med. Sore throat tends to go away on its own, but that would go away too. You're right. You're exactly right.
Yeah. For me personally, I can tell you that if I didn't have a lot of good information when I started using a GLP medication, I can see that there would have been times where I would have stopped. I would have just said, like, maybe the juice isn't worth the squeeze here. But yeah, I do know now that sticking with it was important. And, any of the kind of earlier side effects that I had really are gone now. I mean, I'm doing 12 milligrams of Zepbound right now, and I don't have any nausea at all.
Well,
like nothing. So
yeah, that's great.
Yeah, it's sometimes your body's got to get accustomed to what's happening. Am I right about that, to equate those two ideas?
I think so.
Yeah.
Every medicine has potential side effects and effects. And sometimes the side effects are not tolerable. And then that dictates what happens. Mm-hmm. But many times the side effects are known, tolerable, and go away. And you get the effect. So it's important. Every medicine has a benefit and a risk. So it's important that you look at medicines just the way you're talking about the Zepbound. Look at medicines that way.
So when you presented at ADA, is that where you presented the information about the Inhale study?
Yes. Along with a number of other excellent presenters, we had about an 1.5-hour session at ADA a few weeks ago. 7 presenters got 10 minutes each and amazingly stayed on time.
That is amazing.
We presented the INHALE-3 study.
What have you not said so far in our recording from the study that you think people would be interested to know about?
Scott, if it's okay, let me walk through the study in a real general kind of way.
Yeah.
And because the study is in people that we take care of in practice, and people who agreed to go on a study, and some of them took a bit of a leap because automated insulin delivery with the pump, and the people you wouldn't expect to go on a study like this, and the other people took a leap as well. Some of them had never heard of inhaled insulin, and 1 or 2 had been on it before, and they'd gotten off, so they could still participate in the study because it was they got back on it. It really is very typical patient types in the practice. And these were people with type 1 diabetes. This was a study that was done around the country, by the way, 19 sites from Joslin. I won't name everyone, but I'll just say Joslin, Northeast, Mount Sinai up in the Northeast, University of North Carolina, Atlanta, and also Texas Diabetes and Endocrinology right here in Austin, a group in San Antonio, Diabetes and Glandular, UT Southwestern, Barbara Davis did it. Las Vegas Endocrinology, Sansom Diabetes, Loma Linda, University of Washington, all over the country. Mayo, too, Northwestern, and all over the country, 19 sites. And the entry criteria was people had to have type 1 diabetes, and they had to be adults. They could be on automated insulin delivery. They could be on just a regular old pump without automated. They could be on multiple daily injection. If they had asthma, just to emphasize this, if they had asthma or history of lung cancer, they could not be on the study. It turned out that about 48% were on automated insulin delivery to start the study. Now, the way the study goes is that people are going to be placed on Degludec, which is Tresiba, plus Afrezza, or they're going to be left on their usual care. It's going to be about half and half. Mm-hmm. So about nearly 50% of people on pumps. Now, what does that tell you? I think that tells you that though we love pumps, and I love pumps, not everyone on a pump is just totally enamored to the point that they want to go on forever. They wanted to explore something maybe a little different. And that's kind of interesting. And we should be open to that possibility. And sometimes I think we're not. So most of the pumpers, it turns out, were on the Tandem or the Omnipod. It turned out there were about 123 people that were randomized, 62. That means, of course, they're put into one treatment group or the other. About half into, again, Degludec plus Afrezza. And we call it in the presentation technosphere insulin because we're not supposed to use brand names in front of a group like a continuing medical education group at the ADA, or usual care. Now, usual care was they stayed on what they were on. And it was a 17-week study. We did try to titrate the doses, and the way we calculated the dose of the Afrezza was that we would multiply the usual dose by 2, and then we would round down to the closest dose of Afrezza. So bottom line, we were doing exactly what I mentioned earlier. We were doubling the dose of Afrezza, recognizing that only about 50% in each cartridge gets absorbed. And we did a what's called a meal tolerance test at the first of the study. And the people on the Afrezza took Afrezza beforehand, and the people on usual care gave the insulin however they normally gave it afterwards. And I'll tell you about that in a minute. The baseline A1C when people entered the study was about 7.6, with, of course, some variability, but that's kind of the general part. I can tell you with the baseline meal challenge that we did, again, the Afrezza versus the usual, the glucoses were clearly lower, out to about 90, 120 minutes than the people who got Afrezza. I could go into a lot more detail, but the Afrezza gets in quickly.
Stops the spike.
Yes.
That's it. Yeah. It gets ahead of a spike, right? And without having to pre-bolus at all.
Yeah, that's right.
Okay.
That's right. They didn't have to, they gave the insulin right when they started to eat. Thank you for pointing that out.
Yeah. I mean, it's a big deal because it takes away from that having to remember 15, 20 minutes, depending on what my blood sugar is, et cetera, and so on. It's a lot to.
That's right.
Yeah.
That's exactly right. One of the people who I know pretty well who was on the study would be in various meetings, and he could just kind of whip out his little inhaler and dose himself right before a snack or eating. And he didn't pre-bolus, did not do that.
Is the 2 ever too much? The 2-unit cartridge, is it ever too much where people are like, oh, I have to eat more than I want to because I can't go lower?
It could be, but I have to admit I haven't seen that happen. It's the 4 unit is the 2 is what you're talking about.
Yeah.
And that's such a small amount. I have people who are very sensitive. I saw someone early this morning is on a basal of like 0.2, and I actually reduced it a little bit. So, plenty of people with type 1 are very insulin sensitive, and many are really almost type 2-ish in their insulin resistance. So a lot of variability.
Okay.
Yeah.
All right. Interesting. Go ahead. I'm sorry. I didn't mean to cut you off.
No, that's a great question. And now in terms of, so that's the meal test. That's one outcome. The other was A1C. So let me just pose the question to you and the people who listen to this. And do you think that inhaled insulin with basal insulin given one time a day, Tresiba, Degludec, as a background could compete when it comes to A1C with an automated insulin pump?
I would think that anything that stops a meal spike and can quickly defeat a stuck high blood sugar without causing a low that would cause me maybe to treat and rebound high would have a better chance.
Right.
Yeah, that's my expectation.
Yeah. Well, you're right on. I think there were hopes that the A1C would be lower with Afrezza because there was reason to think it could be. Mm-hmm. But competing against, not everyone was on automated insulin delivery, right, or the automated insulin pump in the control group, but many were. It turns out at the end of the day, A1C was the same in both groups.
Really?
So Afrezza was not inferior. That I think that's quite an achievement. And there's more to it, though, when you delve and kind of dig into the actual data. And bear with me here. I'll try to make this as clear as I can. The proportion of people in the study who achieved A1C levels below 7%, 30% with Afrezza, 17% with usual care, which of course included the automated pump. Mm-hmm. And 21% of those on Afrezza had A1C improvements of 0.5% or greater, 21% versus just 5% with usual care. Now, you're thinking, well, how did the A1C turn out to be the same then? Well, it turns out that some people actually got worse. So 26% of people had about a 0.5% worsening with Afrezza compared to just 3% of the usual care. And the bottom line here is that not everyone does better with Afrezza or as well. And you really have to be someone who's willing to actually dose sometimes between meals when you have a high and be ready to do that. And
is that what you saw, that people would just kind of stare at high blood sugars and not do anything about them?
Yes.
Yeah. So
at times.
Okay.
We did instruct people in the study that if their sugar after a meal and after the previous dose was over 140, then they could dose again at 1 or 2 hours after. Because for two reasons. One, we're aiming for very good control. Two, we know it doesn't hang around. They're not going to stack. Their chance of stacking is much lower, put it like that. Many people did that and were watching their numbers and would set their alarms and just do it. And some people just didn't want to do that. And that's pretty typical of what we see in practice in general. I mean, we do see that.
Tom, that's almost an argument for automated insulin delivery, because at the very least, if you go to a 224, your algorithm is going to keep pushing when the person maybe who's either unmotivated or distracted or whatever is not going to do something again.
Yeah.
Yeah.
Let me say something about that. And that makes logical sense to me too. It turns out, and I'm, ask me in a minute, that quite a few people who had been on the automated pump who were in the Afrezza treatment group actually stayed on the Afrezza afterwards. So it's like anything else. This is an option.
Sure.
It's really not designed to compete with the pump, but this was a brave study in a way to actually allow it to compete against automated insulin delivery, and it did actually quite well.
Yeah.
And quite a few people decided it was in their interest to continue on.
It would occur to me that there's probably like three outcomes here, right? Either I listened to the direction and, either stayed where I was or did better, and I don't have to wear a pump anymore. So great. or I did the minimum I needed to do, and even my A1C went up a little bit, but I love not wearing a pump, so I'm down for this. If
that's it.
Yeah, or I guess the other option is somebody who's super motivated and really paying attention could probably trim an A1C in the 5s with this if they were paying attention and on top of it.
Sure.
Yeah.
I think you're right. And this idea of pumps are great. Automated is great. I love them. We do studies with them. We use them in clinical practice. We use every one. They're wonderful. I mean, it is so nice. Yet, many people really don't want to have the apparatus on their person.
Yeah.
And many people would just as soon have, and I learned a new term, a pumpcation, and sometimes they want it to be pretty long. So if there's an alternative for them and gives them the ability to interact, they may take it. So I would never have thought a person with a pump was a candidate for a Afrezza, but I know better at this point based on the study. But your point's a good one. I mean, some people really do just very well overall with the automated insulin pump.
Right. Now, I mean, listen, it's my expectation. I mean, I've been making this podcast for a decade now, and it would have been easy for me in the beginning to get lost in the idea that like, oh, everybody wears a pump or everybody tries really hard all the time. But that just seems to be the people that the podcast attracts, either people who are desirous of living that life or want to get to it. Right.
Right.
I don't know the numbers, but I wonder if you do. The percentage of type 1s wearing pumps is not as high as I would think it is. Is that correct?
It's pretty high. And it depends. It's going to depend a lot on various regions, practices, things like that. But I don't know the exact percent, but it's at least 2/3 at this point.
Oh, that's fascinating. Yeah,
it is fascinating.
Okay.
It leaves a high percentage of people, though, really that aren't on. You would think that the technology would kind of bowl people over, but there are reasons not to wear a pump. I mean, one is it's something you have to wear. The other is the catheter, one way or the other, is in constantly. And life situations like going swimming, some things are just more complicated. Things getting pulled off, falling off, and things like that, like catheters and that too. And this gets back to the idea of option. We should be giving people all of the choices and letting them experience and let them decide and not just say, hey, you're a pump person. Let's do it.
No, I'm a proponent of that. Yeah. There's a lot of different ways to hack your health situation, and at the very least you deserve to know what they are.
That's right.
Yeah, no, I agree with that totally.
I totally agree.
What are we missing here? Anything?
One thing that was really interesting about the study is that it's a short-acting insulin. I've said this before, and we found that when people dosed at bedtime, they did better. And people are so cautious and have been so cautioned against dosing a couple hours later, stacking. And people have been told, oh, don't take that insulin bolus, don't take much at bedtime, you'll get low overnight, because the current sub-Q insulins hang around. Even the fastest, as I pointed out, and I talked about the fastest a while ago, they hang around. And if you dose at bedtime, you could get in trouble. Yeah. This one, you really need to guide the insulin at bedtime, and it's a big deal. And this one, inhale, gets in, gets out, and it's not going to hang around. And so we did learn that dosing at bedtime was really important when it came to improving control.
Yeah, I mean, I preach all the time to people. First of all, you can steal A1C overnight. It's the easiest time because there's no carbs usually. And, making a thoughtful bolus at a meal definitely stops you from having to address it again later, which is very likely going to lead to a low if you're not real adept at it. So, yeah, but for those people who are missing and coming up on bedtime, they're very willing to go to bed with a 200 blood sugar or greater to avoid the risk of even getting low overnight. And then they'll start their next day high, and then it's just a perpetual circle they can't get out of, which is, I think, a lot of the ways where we start to accept, oh, my A1C 7, oh, it's 8, it's okay. You know what I mean? There's nothing I can do about it. Like that the mindset around insulin is, and lack of tools and understanding are pretty much the drivers in poor outcomes, I think, at least. Yeah. I see the value 1,000% of being able to just say, look, I have a 200 blood sugar here. I can puff this in real quickly and an hour from now, 90, would you say 90 minutes, and maybe 3 hours from now at the greatest, this impact's gone for me now.
Sure.
Yeah.
It's gone. You could redose it in 1 or 2 hours. That's what we found. That was safe, and it worked. And if you've need to guide your sugar down, you could guide it down with a quick hit.
Yeah.
And that was true after meals, between meals, bedtime, and people learn to be comfortable with that because they've learned to not be comfortable. Like, I dare you to take another dose of sub-Q insulin 2 hours after you eat and not get low, or I dare you to take it at bedtime. We always have people take at bedtime to guide their sugar with sub-Q too, but it's just a little different. You have to be cautious because the insulin does hang around. You don't want to leave the glucose high with either type of insulin.
I have a specific way I talk about stacking because I genuinely believe both things. First of all, it's not stacking if you need it, it's bolusing. But that infers great settings and a great understanding of timing on your part. And then, otherwise, stacking is 1,000,000% going to lead to a low blood sugar later that is probably going to take more carbs than you imagine to stop. And and so you have to keep, until you know what you're doing, the idea of bolusing inside of the window where the previous bolus is still active is, it's an issue because you very likely may do it wrong. Once you know what you're doing, I just think of it's bolusing at that point. If I know I need it, then you use it.
Right.
And that doesn't lead to a low, which people also have trouble. Like when I talk to people, you can see them processing it. They're like, well, I ate and I ate again an hour later. I'm like, well, yeah, well, you should bolus again. And they're like, oh, won't I get low? And I was like, won't you get high if you don't? And they're like, yes, that's a person who knows their settings work. You know what I mean?
Exactly.
But another person who doesn't, was I talking to somebody the other day that said that they're on a pump. They see people on pumps who see doctors and still have A1Cs in double digits. And I think, how is that even possible? They don't have a good lead into this. Their settings are way off, or their understanding of insulin is significantly off.
Right.
So do you think that Afrezza is more of a ninja level, or do you think that everybody could use it successfully?
I think Afrezza, well, let me back up. I like that analogy. I think Afrezza is one of the, what is it, a green belt?
Okay.
That's a starter. I think Afrezza should be talked about at green belt, and it may make a person a black belt if they use it the way it can be used. I think it goes all the way up. I think it's something we should be talking about from the get-go. Let people have the option of it. I don't think I'd wait till any particular time and say, oh, now you're a Afrezza person. I hope I interpreted your question,
you absolutely did. Yeah.
Somewhat closely. Okay. I think it's something we need to talk to people about right off the bat. If it fits their personality, their life, their thinking, their approach, then they need to know about now. And frankly, they really need to try it. We try everything along the way. Anybody on a pump has been on probably every insulin, basal you can imagine, every bolus you can imagine, but most likely they haven't been on Afrezza. That is something we need to grapple with as people who prescribe and talk about options. People should have the options and should be allowed to try them.
Do you find, though, that doctors, if they don't understand it well and the whole 4 is 2, this is that, like, might stop them from understanding it? Like, are you fearful, I guess, that this won't get the foothold it deserves in the community?
And I'll also say it already has had that happen. I do think that this INHALE-3 study, and I'll tell you more about kind of what we learned here finally as I close out talking about it. I think it really gives us a foundation better than ever. We already have foundations. This is not like the first study. There have been a lot of studies. This is a really good one, though, that tells us about the here and now. What about against automated insulin delivery? How do you use it? What are the proper concepts that we learn from ourselves and from our patients mainly? And how do you use it? And so I think you're right. I think that people don't understand how to use it, therefore they shy away from it. That's one thing. Second thing, I think we've made these assumptions that people on pumps want to stay on pumps forever. We could keep talking about other insulins for them. Thirdly, there have been reimbursement issues, and people have sometimes knocked their head against a brick wall when it comes to reimbursement. That's getting a lot better in our experience. And frankly, if we think an option is good for a patient, I'll say we need to go to bat for it, and we do. We do. After what I'll call the GLP-1 wars, when it comes to getting things reimbursed and paid for, I think we're pretty good at going to bat when it comes to getting things covered. So I think that whole reimbursement thing's better now too. So there are a few kind of little blocks that have occurred along the way.
Yeah.
Knowledge and reimbursement that are better now. And I think this study has taught us so much. And our next job is to get all that information out to everyone in the people that prescribe insulin world.
Yeah, I agree with you. I'll tell you, it took my daughter's endocrinologist the better part of 2 months to talk our insurance company into covering her GLP medication.
Right.
Yeah. And it was more about being on the phone talking. Like the sending what they asked for worked at first, but then of course a month later they were like, we'll do it again. And you know, I'm like, are we doing this every 3.5 weeks? We're gonna have to reevaluate. Like what's happening here? So she finally got them on the phone and walked them through it. And they said, what did they give her? They gave her a 3-year window for GLP.
Really?
Yeah, they're going to reassess her. They're going to reassess her again in 3 years.
That doctor is very convincing. Yeah. I must say, very persistent, and I admire that. We do the same. We try to do the same thing here, and with GLP-1s for people type 1, for Afrezza, and it's just the world we live in. I mean, growth hormone. I'm an endocrinologist, and I prescribe things outside of diabetes, of course, and cholesterol meds that are hard to get. We're just used to it. Yep. And unfortunately, we really have, fortunately, we know how to do it, but unfortunately, we have to go to bat repeatedly, and we do that.
She's interesting because she's not, she wasn't born here. So she has a less American idea of how things should be, but she's been here long enough that she understands how things work. And so I think not growing up in the system allows her to fight against it easier, if that makes sense.
Yeah.
But anyway.
It does.
Yeah.
Yeah. That's impressive. My hat is off to her. All right. Good.
Finding her was one of the luckiest things that ever happened to my family, actually. Dr. Blevins, I really do appreciate this. I needed somebody who could talk about this. And I learned from the GLP conversations with you, you were the exact right person to talk about things like this with. So I hope to have you back again on other topics.
Cool.
Thank you.
Do we have a few more minutes?
Oh my gosh, if you do, I was over your time. I was trying to let you go.
No.
Yeah,
okay,
go ahead.
Let me close out with a few comments, some of which are redundant, truly. But and great. No, this has been fun. This is talking to you is a lot of fun.
I tell you, Tom, you and I seem to get along very well. I expect you're going to be on this podcast for years. So thank you.
Well, I'd be happy to.
Yeah.
I may have to put off the screening one a little bit. I've just got so much going on right now. But anyway, back to Inhale. Mm-hmm. You know, some things we learned in the Inhale 3 study, and this is a little bit of redundant, but these are a big deal. And I hope to get this information out as soon as possible to people who prescribe insulin, people who are, first of all, very involved in their own self-management. They're perfect for Afrezza. And if they want to reduce hyperglycemia, this is a good way to guide the glucose down. And people who would like to try something other than a pump, this study showed this was a very, very, very good alternative. And this thing about wrap it in, wrap it out, that is just golden. Mm-hmm. I mean, we could redose people 1 to 2 hours after a meal, and we didn't see an increase in hypoglycemia at all. And we had actually people, some people roll their eyes here, but we had people set their alarm at 140 and dose over 140. And I'll tell you, not everyone did that, but the ones who did well. And so people are going to have to be, I think, okay with multiple or extra dosing.
Yeah.
But this is something they've wanted to do for a long time, I think.
The people you're talking to on this podcast, my daughter's high alarm is at 120. So you're not scaring you're not scaring them with 140. Don't worry.
Well, thank you for saying that.
Yeah.
Because I felt I was imposing on people in the study. I'd say, set your alarm at 140. I'd kind of look at them like, are you going to throw something at me? But no, I'm glad to hear that. That is so good because it works so well.
Yeah. I'd rather use a little bit now than a lot later. That's just the way I think about it. So go ahead.
And the other part here is that people who completed the extension phase, there was a second 17 weeks that I don't have information on yet, but afterwards we asked them, do you want to continue Afrezza? And I can just tell you, if they were on multiple daily injection before the study, and we said, hey, you can go back to whatever you want. 60% wanted to stay on Afrezza. Mm-hmm. If they were on pre-study automated insulin delivery, the fabulous automated pumps, well, I don't know. I'd love to ask people what percent of people they thought would want to stay on Afrezza. It was 43%.
Oh.
And then if they were on just regular pump without the automated feature, 60% wanted to stay on Afrezza. Now, maybe they selected themselves out to try something different. Okay, maybe so. But that was amazing to me.
Yeah.
And so why would you use, in conclusion, why would you use Afrezza? Patient's choice is number one. And number two, we talked about the in and out. It's discreet and convenient. There was a day when I would have said the people that are the best candidates are people who are needle phobic and people who had lipohypertrophy, that fatty buildup that occurs when people give injections in the same place. But really, those are at the bottom. They're not low. There are good reasons, but they're at the bottom of the list. Patient's choice is number one. And then we talked about the conversion thing. And, in the study, we allowed people to flex the insulin. We learned that if they're going to have a big meal, they could take an extra 4. If they're going to have a small meal, they could subtract from their Afrezza dose, and then they can adjust their dose just the way they do with other types of insulin. And we did have people correct 60 to 90 minutes after they ate. And we had them sometimes interact with their rate of fall that they're seeing when they dosed, rate of rise too. So maybe a little less if it's falling when they're dosing, a little more if it's rising. And I'll just also comment that in our site here, we had, I think, 8 or 9 people on the study here in Austin. And we had about 4 of those who wanted to stay on. Oh, that's right. We had more than 50% who wanted to stay on Afrezza at the end of the study, whether they were on MDI, the automated insulin pump. Yeah. People liked it for quite a few different reasons. And so it's easy for travel, exercise, quick in, quick out. I mean, you could talk about scenarios quite a bit. So
you don't have to refrigerate it when you carry it. Is that right? Does it have to be refrigerated when I carry it?
Once you take it out of the blister pack, it can stay room temperature for about 3 days.
Okay.
Now you'd want to keep your stores refrigerated, but the supply that you're going to use the next few days can be at room temperature.
Wow.
Yeah.
Yeah. And thanks to the people who do these studies, by the way. And Tom, if people want to jump on a study, can they contact you? I know you seem to have some running almost all the time.
The Afrezza study is over, and I don't have another Afrezza study on the way. We are doing some studies on people with type 1 diabetes who are especially on multiple daily injection of medicines that are kind of like Ozempic, the GLP-1s. And we're trying to get a drug approved for type 1. That'd be great with GLP-1. And, as you said, your daughter's practitioner had to, really go to bat to get it approved. And hopefully that could be a thing of the past in the future if we get something approved. So we're doing studies in people with GLP-1s. We're doing a study with a medicine that might help reduce hypoglycemia in people with type 1 as well. So if anyone in the Austin region is interested in talking to us about studies, we'll be happy to talk to them. They could call the Texas Diabetes and Endocrinology and ask for the clinical research department.
Nice. That's excellent. Thank you. I let you get everything out?
You did.
Great. Would you hold 1 second for me? I just want to ask you something when we're not recording.
Yes.
Oh, great. Thank you so much for doing this again. I really appreciate it.
Thank you, Scott.
Oh, it's a pleasure.
Enjoyed it.
A huge thank you to one of today's sponsors, Gvoke Glucagon. Find out more about Gvoke HypoPen at gvokeglucagon.com/juicebox. You spell that GVOKEGLUCAGON.com/juicebox. US Med sponsored this episode of the Juicebox Podcast. Check them out at usmed.com/juicebox or by calling 888-721-1514. Get your free benefits check and get started today with US Med. A huge thank you to Eversense CGM for sponsoring this episode of the podcast. Are you tired of having to change your sensor every 7 to 14 days? With the Eversense CGM, you just replace it once every 6 months via a simple in-office visit. Learn more and get started today at eversensecgm.com/juicebox. Hey kids, listen up. You've made it to the end of the podcast. You must have enjoyed it. You know what else you might enjoy? The private Facebook group for the Juicebox Podcast. I know you're thinking, Facebook, Scott, please. But no. Beautiful group, wonderful people, a fantastic community. Juicebox Podcast, Type 1 Diabetes on Facebook. Of course, if you have Type 2, are you touched by diabetes in any way, you're absolutely welcome. It's a private group, so you'll have to answer a couple of questions before you come in. We'll make sure you're not a bot or an evildoer. Then you're on your way. You'll be part of the family. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. If you're not already subscribed or following the podcast in your favorite audio app like Spotify or Apple Podcasts, please do that now. Seriously, just to hit follow or subscribe will really help the show. If you go a little further in Apple Podcasts and set it up so that it downloads all new episodes, I'll be your best friend. And if you leave a 5-star review, I'll probably send you a Christmas card. Would you like a Christmas card? Hey, what's up, everybody? If you've noticed that the podcast sounds better and you're thinking like, how does that happen? What you're hearing is Rob at Wrong Way Recording doing his magic to these files. So if you want him to do his magic to you, wrongwayrecording.com. You got a podcast? You want somebody to edit it? You want Rob.